My name is Dr. Clement Nmuka. Today, I would like us just to talk about a condition of a patient who presents with fever, first of all. And this fever is followed by a general condition of being unwell, malaise. And the next, the patient gets a deep pain on the trunk, a deep pain, and the patient doesn't have any explanation. The next thing, the patient is busy scratching because of the pruritus, the itchiness. The next, the patient has an abnormal sensation, an exaggerated sensation, hyperesthesia. The patient has got pins and needles. Then the patient starts saying, man, there must be something wrong with whatever is wrong here. And then this points towards an abnormality in the nerve. Then the patient, whilst observing that, the patient starts seeing some red nodules on the skin. And these nodules, in no time, they erupt into vesicles. And these vesicles have a fluid, and the fluid inside is clear. Sometimes some vesicles have pussy fluid. There's pus in the vesicles. Then this is the time the patient is taken to the lab for sampling, because sampling of that fluid from the vesicles will give rise to some kind of a diagnosis. The lab does the examination and finds that in this fluid there's varicella virus. In this fluid there are eosinophils. Eosinophils are those leukocytes or the white blood cells that you see whenever there's maybe parasitic infection. And then, interestingly, the lab did something else, did another test, and found that there are antibodies against the varicella virus. So 3 findings here, they point towards varicella virus infection. The only history that we get is that at some stage during childhood, this patient of mine is 56 years old. But in childhood, he had chickenpox. So now this clinches the diagnosis. This clinches now the diagnosis. Because now this is now what is known as a herpes zoster. The actual organism is the varicella virus, the organism that's there. But it has been lying dormant for all these years. It has been lying dormant in the root ganglia. The root ganglia has been housing this and kept it dormant for all these years. So now there must have been a problem. There must have been a breakdown of that immune surveillance That breakdown of the immune surveillance has given rise to this eruption of vesicles. And of course, now we know what are in those vesicles. We know that there's varicella virus. So, and what edges us to actually treat now is the problem of pain. There's what is known as neuralgia, the pain of the nerve. The nerve, you remember the nerve is supposed to is supposed to find out what's going on in the environment and sense whatever is there. But now the problem is the attack is with the nerve itself. It was supposed to. So what has happened here? This varicella organism has been lying dormant in the root ganglia. So now it has started now to multiply because the dormancy period is over because of the breakdown in the immune surveillance. The dormancy period is over. So now it is now multiplying. It has been reactivated to actually multiply. It was kept dormant. It was not multiplying at the time because it was kept dormant. Some people try to explain this because we don't really know what the trigger is. But they're trying to explain it and say the antibodies which were looking after the virus and kept it dormant have been neutralized. And of course, that tends to be believable because now there's nothing watching over these viruses, the varicella virus. It's multiplying. But the multiplication causes something else. It causes inflammation. Whoa, we can't have inflammation. We're talking calor. We're talking heat production. That is why the temperature of the patient has gone up. The patient has got fever. The patient has got. It's because of the inflammation that is actually developing there, because of the multiplication of the varicella virus. So there's dolor. Inflammation. Those are the characteristics of inflammation. Dolor, which is pain. Neuralgia is unbearable. So that is why we have to come in and stop the neuralgia. And in fact, to actually shorten the period of the zoster, this is herpes zoster. We've got to shorten this period. How do we do that? We've got to go against the virus, because we know that it is the multiplication of the virus that causes the problem, that in fact leads to inflammation. Inflammation is not what we want here. We don't want inflammation. We don't want the redness of the tissue, rubor. We don't want that. But what is pressurizing us is the pain. So what do we do to counter this? At least we know antivirals. Which antivirals are we talking about? I'm talking about interferon. I'm talking about vidapirin. I'm talking about acyclovir. From vidarabin, acyclovir. If acyclovir is not there, famciclovir will do well. If famciclovir is not there, valacyclovir will do well. We want to shorten the period of the zoster. The zoster is the one that is problematic, that is giving rise to this inflammation, that's giving rise to this multiplication of the replication of the virus. So now we want to shorten the period. And the only way we go antivirals. Now, when you go antivirals, what then? Okay, antivirals are going to shorten the period, and in fact, they will stop. We are worried about, because if we don't do it, we're going to get what is known as postherpetic neuralgia. Postherpetic neuralgia is a problem because it's chronic pain now. Chronic pain. We don't want this. We can't control this acute pain. Now there's going to be chronic pain because of postherpetic neuralgia. So what do? We go on to, with this, amazingly, a lot of things are being done. There's not one way of doing it. We start on the zoster itself. We start using calamine. And we're still going to talk about other topical treatments. But then now, the systemic treatment that we need to think about, we need to think about the adjuvant drugs that we can use. We've used the antiretrovirals. Sorry, not the antiretroviral, but the antivirals. The antivirals. Antivirals, like you said, interferon, vitarabine, acyclovir. If acyclovir is not there, you use famciclovir. If famciclovir is not there, you use valacyclovir. But that's not all. We have to think now about what type of a patient do I have in front of me? Do I have an immunocompromised patient, or do I have an immunocompetent patient? Because this is important now, because it's going to determine what type of systemic treatment should I actually give. For instance, if it's an immunocompromised patient, I'm not going to give the corticosteroids at all. Corticosteroids are very helpful to immunocompetent patients, but I'm not going to use it. I'm going to use the non-steroidal anti-inflammatories like, the brufens, the diclofenacs, the indomethacins, the Indosit. I'm going to use those with patients who are immunocompromised. I'm going to make sure that I don't use corticosteroids. Corticosteroids, I'm going to use them when I'm treating immunocompetent patients. Right. So that's what I'm going to do. Man, as I say, this starts from what? From a ganglion. It was the virus was stored in a ganglion, in a root ganglion in particular. Root ganglion. The root ganglion. Sometimes this root ganglion, you can get a cranial nerve known as maybe a geniculate ganglion. Geniculate ganglion, and then you will get a facial nerve that comes from it and goes, and that facial nerve, remember, multiplication of the virus in the ganglion, the geniculate ganglion, multiplication of the virus, and then it goes to the periphery. It goes with the facial nerve. Now, what is it doing to the facial nerve? It is causing inflammation of the facial nerve. That inflammation, it eats away the facial nerve, and the facial nerve becomes now paralyzed. And when it's paralyzed, you have what is known facial nerve palsy. You've got pain in the face, and it's a weak face, pain in the face, even in the ear. You've got that. So if there's a zoster right in the face, right on your face, you've got a zoster, and at the same time, you've got a face that's actually very weak, and you've got the zoster there. That's given a special name. We call it Ramsay-Hunt syndrome. A Ramsay-Hunt syndrome. This is the type of syndrome that we normally see with HIV-infected patients. Sometimes you don't even know that the patient is HIV infected. You just see this zoster. You just see this herpes. The herpes zoster, and then you see the facial nerve being paralyzed, facial nerve palsy, which goes with this zoster. That's your Ramsay-Hunt syndrome. So you normally, like I say, you normally see it with patients who are HIV infected or immunocompromised somehow. But HIV infected patients, they like having this. But this is the problem. Sometimes you can get a the inflammation starting from a ganglion of a trigeminal nerve. You know, once you have the trigeminal ganglion being inflamed and the multiplication of this varicella virus taking place there, and then going with the trigeminal nerve. We know that the trigeminal nerve has got three components. Has got the ophthalmic component, and has got the mandibular component, has got the maxillary component. But if it chooses to go with the ophthalmic component, we get a terrible pain in the eye, because it starts from the upper eyelid and it goes to the brow, it goes to the forehead, and when it goes to the forehead, it causes that zoster there. And this is terrible, because this is one of the worst, because it can cause, the corneal damage. It can cause the sclerotic damage. The sclera of the eye is actually damaged, and we've got to protect this eye. This is a zoster. This is a eruption of vesicles which is taking place right on the eye, and then we've got to protect it against a secondary infection, because it can be infected, because this is an eruption. We don't want, this is the last thing that we want. We don't want it in the eye, right? Sometimes if you have this if another cranial nerve is affected, for instance, the oculomotor nerve is affected, you might see a conjunctivitis, the inflammation of the conjunctivitis. You might see that. You might see the extraocular muscles being affected, and when they are affected, they become flabby. They become weak, and when they are weak, the eyelid is going to droop. You'll have a drooping eyelid, so you'll have ptosis. Because of. So this is sad. If it mustn't touch these cranial nerves. Sometimes, and if it touches this one again, this oculomotor nerve, you can have a problem of paralytic mydriasis. Paralytic mydriasis, first of all, it needs to be explained a little bit. If the muscles of the oculomotor has got a neuralgia itself, so that it becomes weak, so the extraocular muscles are going to be weak, and they will not, to an extent that the muscles which control the iris keeps its size because of those extraocular muscles. But if the extraocular muscles are weakened, there's going to be a dilatation of the iris. That dilatation of the iris is called mydriasis. So you can have a paralytic mydriasis because of the involvement of the oculomotor nerve. This is interesting. This is good to know, because you will know when you're referring the patient to your ophthalmologist, you will know, you'll be able to explain exactly what is happening. And so that's basically that. But now there are drugs, like I say, they are called adjuvant drugs, which are used here. Adjuvant drugs, you start from tricyclic antidepressants, and tricyclic antidepressants, we always like this one, amitriptyline, decipramine, and then we get to another one. They call it mypratilin. Mypratilin is an antidepressant, just like amitriptyline, just like decipramine, mypratilin, and then these, they help very much in treating the actual postherpetic neuralgia. Postherpetic neuralgia has got to be addressed because it's a big problem where there's chronic pain, chronic neuralgia. And in addition to that, we can use now an anticonvulsant. An anticonvulsant of choice is carbamazepine. Please don't forget that. And we can use, we're talking about the adjuvant drugs now that we can use to treat the postherpetic neuralgia. We can use the alpha adrenergic agonists, like, for instance, clonidine. We can use that, and this is very, very helpful. And in addition, these are drugs which are systemic. I mean, if you take them, they go through the whole system and all that. But you can use, like I said, you could use topical drugs. We started with calamine. You can go to the stronger ones. You can go, for instance, to a drug known as, it's a mixture, eutectic mixture of local anesthetics. You know the anesthetic drugs. It's a mixture of them. Start with the known one, with the one that is known, lidocaine. Lidocaine, you mix it with prolocaine, with prilocaine. Prilocaine is very good together. You don't use it as an isolated unit. Prilocaine, you use it together with lidocaine as a mixture. They call this a euteric mixture, and it's a very stable mixture. And you use it on the surface of the as a topical drug. There's another one, capsaicin. Capsaicin. If you use that drug topically, it's actually very good. It's also very stable, just like the euteric mixture. If you use that one helps to break the peptides in the afferent neuron. It breaks and it makes it's responsible for what is known. It makes sure that, of course, the herpes zoster breaks those, but it breaks those peptides. But breaking those peptides, you need something that can help that, and that's capsaicin. Capsaicin is very good in doing that as a topical drug. So you've got these two topical drugs, and actually there are three of them, started from calamine, and we came to the euteric mixture of the local anesthetics. And we said, as an example, is your prilocaine and your lidocaine, and together, and they'll have very much. And then the capsinogen, and then the last one, and the capsaicin. The capsaicin is very, very good as a topical drug. So this is what you would do to actually treat this condition, and it's one of those. Herpes zoster is amazingly incapacitating a patient, because the main thing is pain. And if you can address the pain using all these, starting from antivirals and coming to the adjuvant drugs, and make sure that you can give your corticosteroids, but corticosteroids you give only to patients who are immunocompetent. Immunocompromised patients, like we said, immunocompromised patients, make sure that you give your NSAIDs, your non-steroidal anti-inflammatories, You're thinking of Indoseed, you're thinking of Brufen, you're thinking of diclofenac. Thank you very much. Thank you very much for listening to me.